All right, so we'll be beginning. Hello, and welcome to MedNews Week Keynote Conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. My name is Madhuri Balasubramanian, and I will be your host today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Drs. Jan Leitman and Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park and Leifman. Our associate directors include myself, Muskan Joshi, Gayatri Menon, and Helena Coloma. Our managers include Alexander Van de Keept, William Wilkerson, Ahmed Aziz, and Viviana Cortiana. Our educational committee includes Rabab Abbas, Gabriel Alves, Blaise Bowers, Harshal Choria, Jenna Ghazal, Sean Jacobs, Shrivika Kannan, Diksha Mahindru, Soumya Nadar, Sukhmani Sidhu, Harshita Valabani, and Imad Ben Zahid. We also want to thank our partners Vimedi, who are a global leader in medical video education, and the National Society of High School Scholars, which is an honor society founded by the Class Nobel, the Nobel Prize family. The moderator for today's event is Gabrielle. Now, to introduce our amazing keynote speaker for today, Dr. Neha Mehta-Shah, who's the Associate Professor at the Siteman Cancer Center at the Washington University in St. Louis. She is an internationally recognized leader, researcher, and lecturer in the field of hematology and oncology. She currently leads multiple local and national trials in T-cell lymphoma, specifically to peripheral and cutaneous. She's a recipient of numerous awards and honors, including the Paul Calabresi Career Development Award for Clinical Oncology. She's been recognized among the top doctors in US by Castle Connolly. She's a prolific author of peer-reviewed manuscripts, abstracts, and book chapters in prestigious journals such as the Clinical Lymphoma, Myeloma, and Leukemia, and etc. She has truly done it all. With that, it's my glorious pleasure to pass the mic to Dr. Mehta-Shah. The floor is now yours, Doctor.
And thank you very much for that very kind introduction. It's my pleasure to speak with you all today about one of my favorite topics, which is how we're making progress in peripheral T-cell lymphomas. These are my disclosures. So we're going to talk about, the currently available treatment for those who have previously untreated peripheral T-cell lymphomas, then review strategies to improve upon that using adding agents to chemotherapy. Then we're going to talk about how we prognosticate in T-cell lymphomas and the use of novel therapies as well. These lymphomas are quite rare. So, when you talk about patients who have lymphoma across the United States, there are about 16,000 cases per year. The rate of that is rising with our aging population. But the term lymphoma really reflects over 100 different diseases in the current classification systems. So how do we break them apart? So the way I teach our fellows and our residents is that the lymphomas arise from a halt in the normal maturation process or the halt of normal ontogeny. And so these, one diagram you see here is in the B-cell ontogeny tree, where you see the development of stem cells to more mature cells. And the same thing happens with T cells. As cells mature and move out of the stem cell niche, they gain and lose certain properties or factors or cell differentiation factors on their cell surface. And when patients develop lymphoma, that means that that particular cell stops learning how to mature and move further in stage. And then how we determine which type of lymphoma patients have is based on what markers are present on those cells, suggesting what the cell of origin is. So to give you a brief example, this is a diagram about B-cell lymphomas. We're going to be talking predominantly about T-cell lymphomas, but I feel this is a little easier to follow. So normal cells, normal lymphoid cells will start off in the stem cell in the bone marrow niche. And as they move from the bone marrow niche out into the peripheral blood and the lymphatic system, they'll gain certain properties on their cell surface, namely CD10. And as they develop further, they gain and lose certain factors. And I treat this akin to how children will mature as well. So, just like an infant learns and gains different properties to become a toddler and to become a young child and then an adult, the cells do the same thing. So if the cells stop differentiating in the infant phase, they become mainly a leukemia. If the cells stop differentiating in the toddler type phase, in between phase, they can become some of the aggressive lymphomas, ones that have left the stem cell niche. As some of the cells learn to find their home in the mantle zone across the lymph node basin. And those, if they stop differentiating there, can become mantle cell lymphoma. And then the most mature lymphomas, such as follicular lymphoma, will come from some of the most mature cells that divide relatively slowly. How do we make a diagnosis of lymphoma? We do this always with a biopsy. So this biopsy can be done from taking out a full lymph node or taking a piece of a lymph node. The bona fide method, or the gold standard, has always been to do an excisional biopsy, but core needle biopsies are increasingly common to make a diagnosis. So most often, at least in the United States, we get PET imaging or some sort of imaging to look for the most suspicious node and then try to biopsy the node that we're most concerned about. This can be done using a core needle biopsy or an excisional biopsy, and in certain types of lymphomas, this can even be done on the blood and the bone marrow. One of the things to articulate is the importance of how the lymph node architecture is. So you may hear that lymphomas, the classification is dependent on the lymph node architecture. Well, what does that really mean? It means that the cell, we're looking at how the cells relate to each other across a lymph node or across the entire picture. So here you can see that there are these are lines representing what a core needle biopsy might take, which is just a pencil lead size piece of the lymph node. And you can see that this lymph node is very different from this lymph node over here. However, when you just look at the part between the two red lines, they can actually look relatively similar. So over here is an example of a patient with follicular lymphoma, and this is a patient who has a reactive population, so not lymphoma, just reacting to an infection or an external cause. And so differentiating slow-growing lymphomas especially can be challenging, sometimes under core needle biopsy, which is why we sometimes like to look at the whole lymph node to figure out how these areas relate to each other. We then establish whether these cells are growing in response to an infection or inflammation like they're supposed to and what they're programmed to do, or whether they're growing in a way like cancer, all coming from the same cells. This is a manner of establishing clonality. So we do this by using immunohistochemistry or staining techniques, flow cytometry, sometimes molecular profiling, as well as mutational profiling. But in general, just like most forms of oncology, no meet, no treat. So without a diagnosis based on a biopsy, we would not proceed with treatment. Immunohistochemistry is looking at staining of proteins using antibodies that are either containing a dye or a fluorescent dye, and then marking how many of those cells express a certain antibody on them. That's probably something that you're relatively familiar with. In lymphomas, we also rely on flow cytometry. So that's taking those same cells, putting them into a suspension, and in the suspension, they add antibodies also tagged to a fluorescent emitter. And you can use many different antibodies at the same time in the research setting, sometimes up to 64 or so, to look at which proteins are co-localized on a cell. And doing this makes it even more efficient to be able to make and accurate to make diagnoses in certain types of lymphoma. And so we commonly use flow cytometry techniques in combination with immunohistochemistry. Additionally, certain lymphomas are characterized by certain genomic abnormalities where certain chromosomes become translocated with other chromosomes, or they lose portions of certain chromosomes. And this can be evaluated by a process called FISH, or fluorescent in situ hybridization, which can usually look for 1 in 200 or 1 in 500 inappropriately rearranged or inappropriately altered genomic structures. And so in order to do FISH, you do need to know what rearrangements you're looking for, and then you test for those specific rearrangements. So it can't look broadly, but it can be extremely helpful to make the diagnosis of certain types of lymphomas. And then there's molecular testing. So molecular testing includes genomic testing. Some of the testing that we use in lymphomas is to look at the genomic sequence of the T cell receptor or the B cell receptor, and we do clonality based on immunoglobulin heavy chain sequencing or the T-cell gene receptor sequencing. And then there's also options to do mutational profiling as well. So with that general overview of how we make the diagnosis of lymphomas, for I know this audience doesn't may not have been familiar with, once you come up with someone having a lymphoma, how do you go about treating them? So specifically talking about T-cell lymphomas make up about 10% of non-Hodgkin's lymphomas. 80% of lymphomas are B-cell lymphomas. And if you take the T-cell lymphomas, they're really categorized into two big buckets, systemic and cutaneous. So systemic lymphomas are ones that are in the body, and then cutaneous ones predominantly start in the skin and then can go into the body, but usually can often also stay in the skin. We're going to be talking really about systemic or peripheral T-cell lymphomas here. So the term peripheral T-cell lymphomas is a rare heterogeneous group. It makes up about 7% of all non-Hodgkin's lymphomas, really reflects almost 20 different diseases in the term peripheral T-cell lymphoma. Most of these patients are a little bit older at the time of diagnosis. The median age at time of diagnosis is 65. And historically, the treatment has really been derived from the treatment of B-cell lymphomas because those were more common. And then those techniques or drugs were then reutilized for T-cell lymphomas. Unfortunately, our outcomes are not as good as our B-cell lymphoma counterparts. About the 5-year survival for most types of T-cell lymphomas ranges about 20%. And the 5-year progression-free survival is only about 30%. And unfortunately, at the time of relapse, multiple registry studies have shown that patients on average live about 10 months. So there's a lot of room for improvement. The term peripheral T-cell lymphomas, as I mentioned, reflects different diseases. We're going to really focus on the more common subtypes. These include peripheral T-cell lymphoma not otherwise specified, also written as PTCL-NOS, anaplastic large cell lymphoma, which then is divided based on the presence or the absence of the ALK protein. This is the same ALK protein that we look at in lung cancer. And then, and also a disease called angioimmunoblastic T-cell lymphoma, or AITL. Anaplastic large cell lymphoma, is pictured in the top diagram, is universally expressed as a protein called CD30. This is important because there's an important therapy that we can give for cells that are overexpressing CD30. They can express that ALK protein as well. The term angioimmunoblastic T-cell lymphoma, or AITL, it comes from we think the cell of origin is called the T follicular helper cell. And these cells have certain specific immunohistochemistry patterns as well. And we've learned that other forms of T-cell lymphoma also come from the same cell. So now the terms follicular T-cell lymphoma, nodal peripheral T-cell lymphoma with T follicular helper phenotype, and angioimmunoblastic T-cell lymphoma, we think biologically are very similar to each other. And we kind of lump those together. And then peripheral T-cell lymphoma not otherwise specified is really a grab bag term reflecting the rest of the diseases that can't be specified in a specific category. There are multiple pathways that have become important in T-cell lymphoma, and we'll touch on some of these. There are agents that specifically work on changing the way genes are expressed. Some of these are called histone deacetylase inhibitors like romidepsin or belinostat, or azacitidine, which is a hypomethylating agent. T-cell lymphomas seem to be particularly sensitive to these epigenetic modifying drugs. Additionally, there's a role for antibody drug conjugates like brentuximab vedotin, which is an antibody to CD30 with tagged to a chemotherapy molecule to deliver chemo to the cancer cells. There's a role for certain antibody-based therapies like mogamulizumab, and then an important role for inhibitors of PI3 kinase like duvelisib, and then traditional chemotherapies as well, like pralatrexate. We know that these diseases behave differently from each other, but recent gene expression profiling data suggests that sometimes the gene expression profiling can even trump how things look under the microscope and help pathologists make a determination of the disease. So this was a study that was done by Javid Iqbal and his group in almost 400 cases, kind of articulating that point. One of the other things that we've noticed is that certain lymphomas not only have the same RNA profile, but they also have common mutational analyses, which becomes important. So angioimmunoblastic T-cell lymphoma and T follicular helper phenotype lymphomas tend to have recurrent mutations also in genes involved in epigenetics. These include TET2, RhoA, DNMT3A, and that we'll get into why that's important in a little bit. The other markers that have been shown to be important are looking at which the cell of origin for these T cells. These includes ones that are hinged on a pathway called GATA3, and as well as a pathway, and alternatively a pathway called TBX21, which each have a different prognosis, where the GATA3 patients tend to have poorer prognosis. And while none of these strategies are actually in the mainstream yet, in terms of gene expression profiling, we hope in the future they will inform clinical decision-making and diagnosis. All this fancy stuff is really great, but as I mentioned, we don't really have that for our patients in real time right now. And we know that we need to do better. So as I mentioned, for most types of peripheral T-cell lymphoma, the overall survival at 5 years is only about 20%. The exception to this is anaplastic large cell lymphoma that overexpresses the ALK protein. Those patients tend to be more chemotherapy responsive to their first treatment. So their survival is poor. And then in addition, their progression-free survival is similarly poor as well. So that suggests we need better treatments for patients in the frontline setting, because there are many patients who don't achieve a great remission with their first treatment. And then the relapse setting as well, there's a huge role for therapies. And the fact that these curves are superimposed articulates that point. Additionally, as I mentioned, patients who have relapsed refractory disease have poor outcomes. Their median survival is only about 10 months. And this is coming from the COMPLETE registry, which was a large US registry that was done. Similar results have been seen in other international registries. But we do know that patients who can achieve a remission and are eligible for an allogeneic or donor bone marrow transplant can have decent outcomes. About the 5-year survival is about 50% for patients who are able to get to transplant. This was seen in a large US series that was led by us, but then was also replicated in an analysis of the CIBMTR. So that's like the Center for Bone Marrow Transplant in the United States, as well as the European Bone Marrow Transplant Registry, where they also showed the 3-year survival is about 60% for patients who do make it to transplant. So if you can achieve a remission in this situation and you're eligible for a bone marrow transplant, that can be curative and lead to good outcomes. So with this information, when we meet a patient who has T-cell lymphoma, some of the first questions we ask are, what's the diagnosis? You learned about how we approach that. And then how do we know where the lymphoma is, or staging? And we usually use PET scans in the United States. CAT scans can be done as well. PET scans tend to be a little bit better for looking at disease outside of the lymph nodes, which is not uncommon with T-cell lymphomas. And then we know that PET scans can miss bone marrow involvement in about 25% of patients who have T-cell lymphoma. So we usually do get a bone marrow biopsy in addition. And the staging for these lymphomas use the Ann Arbor staging system. The cutaneous lymphomas and the implant-associated lymphomas, I apologize, this slide got a little messed up, are staged differently, but most other lymphomas, including most of the T-cell lymphomas, use the Ann Arbor staging system. So if you have lymphomas in one region, then they're considered to be stage 1. If they're in more than one region above the diaphragm, they're considered to be stage 2. If they're above and below the diaphragm, that's stage 3. And if it's in areas outside of lymph nodes, that's stage 4. And just a historical point, these staging system came out of initially the radiation field that were required for curing patients who have Hodgkin lymphoma, back when Hodgkin lymphoma was the first disease to be cured with radiation. So currently, for patients who have initial diagnosis of peripheral T-cell lymphoma, for the common subtypes, excluding the ALK-positive ALCL, I consider giving 4 cycles of CHOP-based chemotherapy. So that's cyclophosphamide, doxorubicin, vincristine, and prednisone, which is a standard lymphoma upfront regimen. After 4 cycles, I see if they're responding. If they look like they're responding, we do 2 more, 6 in total. And then we consider doing an autologous stem cell transplant, or a high-dose chemotherapy and stem cell rescue is the other way I like to term that. The idea there is that if you're responding to chemotherapy, more chemotherapy could eradicate any residual cells, and then giving your own stem cells back helps repopulate the bone marrow and helps your recovery from the transplant. But the main objective of the transplant is to get more chemo. So this has not been studied in randomized fashion, but multiple phase 2 studies and retrospective studies and registry studies all show the same numbers. That if you have your 5-year survival for most patients with T-cell lymphoma is about 20%. If you take the patients who were intended to transplant as marked in the beginning as when they were enrolled in the registry in first remission, versus if you were not intended to pursue an auto transplant, the outcomes for patients who were intended to pursue an auto transplant first remission is about 20% higher. And so the 5-year progression-free survival and overall survival improved from about 20% to, or 25% to about 40 to 45%. And that's seen consistently. So I always tell my patients there's probably a 1 in 5 chance that the transplant might help you. And we just don't know how to pick those patients yet. So we tend to recommend it for patients who are fit. So CHOP chemotherapy has been the standard, just like it's the backbone of therapy for diffuse large B-cell lymphoma. And people have tried to add chemo to CHOP. For example, they add etoposide, or that's the to make it CHOP plus etoposide. And this was an analysis done from the German non-Hodgkin lymphoma study group, looking to show that the addition of etoposide measured in the red lines improved outcomes compared to patients who did not receive etoposide-based regimens. So we consider this seems to benefit patients who are younger predominantly. And then since then, there's been time and time again that we've really tried to make a difference in T-cell lymphoma. And unfortunately, the spoiler alert is that most of the times these failed. The exception to this are the 3 studies that we're going to spend a little bit of time talking, or 2 of the studies we're going to spend some time talking about in an ongoing study as well. So Echelon 2 is a landmark study of brentuximab in combination with CHOP-based therapy. Remember, brentuximab is that antibody antibody against CD30 tagged to chemotherapy, and that allows for the antibodies to find the cancers, the CD30 positive cancer cells, and then deliver the chemotherapy to the cancer cells. So we call those antibody drug conjugates. And in this study, half of the patients got brentuximab and half of them got placebo, and they all got CHOP-based therapy. We replaced brentuximab, we replaced vincristine with brentuximab to prevent patients from getting neuropathy or numbness or tingling or weakness. This was a randomized international study. And fortunately, in this study, where most of the patients had anaplastic large cell lymphoma, which expresses CD30 uniformly, the outcomes had been tremendous. So it showed that the progression-free survival at 3 years with brentuximab-based regimens improved from 44% to 57%. And this corresponded to a 33% reduction in death, which was the first study ever in T-cell lymphoma to show a survival benefit. This really was most pronounced for those who had anaplastic large cell lymphoma. For the other subtypes, it was underpowered for this analysis, but the results were less impressive for peripheral T-cell lymphoma NOS, as well as angioimmunoblastic T-cell lymphoma. As a result of this, brentuximab, at least in the United States, was approved in combination with chemotherapy for CD30 positive peripheral T-cell lymphomas. So what we learned from this was that the T-cell community was quite invigorated, because they saw that if you had a biomarker and had a drug that works at a high percentage in this patient population, you could add that to other agents that you have currently to result in an improvement in progression-free survival and, importantly, an improvement in overall survival. So biomarker therapy can work in T-cell lymphoma. Other people have tried to augment this. Remember, we talked about etoposide for the addition of etoposide to CHOP-based therapy. Well, so other people, Dr. Herrera at City of Hope has started to ask, well, can you add that to brentuximab-based chemotherapy as well? And this study, which used that regimen, BV-CHEP, so adding etoposide to CHP, resulted in an overall response rate that was very high for all patients, 90% for non-ALCL patients, 94% for ALCL patients. And the early results looked very promising and likely leading to another national study. So more to come with this regimen. Additionally, so we talked a bit about brentuximab. Brentuximab certainly works for anaplastic large cell lymphoma in the relapse setting as well. So in the relapse setting in anaplastic large cell lymphoma, the response rate of brentuximab is close to 85%. So really good. In the other subtypes, it's a little less good, in the range of 30 to 50%. Other agents that have been approved for T-cell lymphoma include histone deacetylase inhibitors. These are drugs that change the way that genes are expressed by cancer cells by associating with the histones. And these include romidepsin and belinostat. And the overall response rate's about a fourth. And then an antifolate drug called pralatrexate is also approved for T-cell lymphomas. The overall response rate there is only about a third. So those numbers don't seem that impressive, but we do know that patients who do have the T follicular helper phenotype, so that's like angioimmunoblastic T-cell lymphoma and its cousins, seem to have a better response to HDAC inhibitors. This was a study that was led by Paula Gioni and Steve Horowitz to look at whether T follicular helper phenotype lymphomas are predicted to have better outcomes with romidepsin-based therapy, the histone deacetylase inhibitor, and the answer is probably yes. This was a retrospective study. So we know that that class of medicines is probably helpful for that particular subtype of the disease, hoping that we can start to create more personalized treatment approaches for patients. So that sort of data had been part of the development of this study of which was done by the LISA group in France, where they compared CHOP to giving romidepsin with CHOP for patients who have peripheral T-cell lymphomas. And what they found was there actually was not a difference in outcome, unfortunately, in this large randomized study. However, the patients who had angioimmunoblastic T-cell lymphoma, who we think are hinged more on this mechanism, seemed to have the most degree of improvement, but the study was not powered for just that subgroup analysis. And so, unfortunately, this study did not lead to a positive result. We mentioned earlier on that histone deacetylase inhibitors and hypomethylating agents are also important in T-cell lymphomas. So azacitidine is a hypomethylating agent, again, also changing the way that genes are expressed by cancer cells. And azacitidine is commonly used for other cancers like AML and MDS, but then there was a series that showed in angioimmunoblastic T-cell lymphoma, it seemed to work for 9 out of 12 patients in this case series. And we think that made sense because, again, angioimmunoblastic T-cell lymphoma tends to have these recurrent mutations in epigenetic modifying genes. So when oral azacitidine was developed, it was studied with R-CHOP in diffuse large B-cell lymphoma and found to be safe and seems to cause priming of the cancer cells to be more responsive to the chemotherapy, interestingly. And so that led Gia Ruan, who's at Cornell, to study the use of this in combination with CHOP-based therapy in T-cell lymphomas and showed that the response rate was 85% in 20 patients and at the end of treatment was 75%. So this has become quite exciting and led myself and others to start thinking about how we could further study this up front. At the same time, there was the development of a drug called duvelisib, which is a PI3 kinase inhibitor that's been approved for CLL and previously approved for follicular lymphoma. And in the initial studies of duvelisib, we found that the response rate in T-cell lymphomas was impressive. It was about 50%, but only in less than 20 patients. So that led to a large international study, potential registration study of duvelisib as a single agent in peripheral T-cell lymphomas. And patients get a higher dose for the first couple months, and then if they're doing well, they can drop down their dose. And it was found in this study, again, that the response rate's 50%, comparing quite favorably to existing drugs that only respond in about a fourth of patients. And this also, it seems like there's a proclivity for angioimmunoblastic T-cell lymphoma to even have a slightly higher response rate than that. Almost 2/3 of patients with angioimmunoblastic T-cell lymphoma on the duvelisib registration study showed a response as well. So that's led to this U.S. intergroup study where patients in the United States who have a lower expression of CD30, like they wouldn't have been qualified to get brentuximab CHP on the ECHELON-2 study, are randomized to getting duvelisib with chemotherapy, CHOP or CHOEP based on the patient's age, CC486 or oral azacitidine with CHOP or CHOEP based on the patient's age, or CHOP or CHOEP chemotherapy, again, based on age. And this study is ongoing in the United States. I'm excited to be a part of that. So people have asked then, well, what can we do to do better by giving therapies after people have gotten their treatment? So there have been attempts to look at maintenance therapies after autologous transplant. One of these studies was done by Neil Furkan and Steve Horowitz at Memorial Sloan Kettering, looking at the role of romidepsin following an autologous transplant, and unfortunately did not meet its primary endpoint. But again, the patients who had angioimmunoblastic T-cell lymphoma seemed to be the ones who improved from this the most. There's an ongoing study looking at duvelisib after finishing an auto transplant that's being led by Amanda Cashin, was co-developed by a couple of our fellows here at WashU. And so that study is also ongoing. So we think that, not only do we need better treatments, but it would be really good to predict from the beginning who's more likely to be cured and who's more likely to have progressive disease. And so some of these are to look at imaging techniques or looking at blood techniques like cell-free DNA or minimal residual disease. So we've conducted a study to look at, can you predict based on someone's scan in between their treatment, whether they're likely to do well? So the answer is yes. So if you look at people's PET scans after 4 cycles, and you see if they had a complete remission, which is in the red line here, they do significantly better than the patients who are on the blue line who did not have a complete remission, suggesting that patients who do not respond, do not have a favorable response to their initial chemotherapy, are likely to have bad outcomes and should be considered for more aggressive strategies, although we don't know the best way of that. There are also studies that we've conducted to look at blood tests to see if you can detect the clone of the lymphoma in the blood while people are on treatment, and to see whether that looking at the blood for cell-free DNA or T-cell gene rearrangements can predict for outcomes. And unfortunately, the study that we had led, including 41 patients at 3 centers, show that unfortunately the end of treatment clonotype using the T-cell gene rearrangement was not predictive of outcomes. In fact, most people were positive, 80%, and that was true for the people who were known to be in a complete remission or had known not to be in a complete remission at the end of treatment. And we're now studying other strategies to look at this as well, using the same patient population. Some of our mentees here, David Russell Germain and Nikki Foley, had looked at, well, maybe not for everybody, but can you use the peripheral blood T-cell gene rearrangement clonotype prior to transplant to predict what their outcomes were? And unfortunately, only a handful of patients really underwent transplant on this study. But if you look at the patients who not have, who had negative blood by minimal residual disease assessment after transplant, that those patients really had the best outcomes at the end, and all those patients were currently alive and well. So an interesting observation, and more to come, I think, on that. Some of this is being looked at in the US intergroup study as well, prospectively in a much larger cohort. So now we're going to flip to talking about novel strategies in T-cell lymphoma. So we talked about the fact that many people relapse, so we should have better treatments for them. And the outcomes, as I mentioned, are relatively poor, but patients who can achieve a remission and go to stem cell transplant can have a good outcome. And so the goal is to really get them there. And there's lots of standard chemotherapies that have been used that have variable remission rates, and those have really been studied in single or multi-institutional retrospective series. Most of them only work for a couple months, if that, and even the most aggressive regimens. And we know that the standard single agent regimens in general, other than brentuximab, only work for about 1 in 4 people, again, with very limited durability. We talked about brentuximab already, the antibody drug conjugate to CD30. We talked already about the fact that in anaplastic large cell lymphoma, this can be a real game changer for patients. In fact, patients who are in a complete remission to brentuximab can have very long progression-free survival, not really reached after 5 years on the initial studies. But in other forms of T-cell lymphoma, like PTCL-NOS or angioimmunoblastic T-cell lymphoma, the results are much more meager. The overall response rate is only 41%, and the median progression-free survival is only 2.5 months. So it doesn't give you that much time in remission, even if you do respond. So some may ask, well, can you use the amount of CD30 to predict who will respond? And the answer, unfortunately, is no. So this was a analysis that was done to look at the level of CD30 relative to whether patients were in a complete remission, and all the black squares and triangles reflect patients who achieved a complete remission, and there's some hovering right near 0, close to 1%, who still achieved a complete remission. So because of the heterogeneity of these diseases, we don't think you can really use that to triage patients to say you shouldn't get brentuximab if your CD30 expression is less than X%. So we usually use, if you have 1% or greater, we consider giving you brentuximab as in your salvage option. We talked about oral azacitidine and hypomethylating agents as being very promising. So in France, in the LISA group, they led a national international study looking at relapse refractory T-cell lymphomas, and specifically only focusing on those who had angioimmunoblastic T-cell lymphoma and its cousins. Those were the agents. That was the class that seemed to be more sensitive to this. So patients either received oral azacitidine or they got the choice of other standard treatments, romidepsin, bendamustine as standard chemotherapy, or gemcitabine as standard chemotherapy. And unfortunately, the response rate to oral azacitidine was not the whopping 75% initially thought. It was only 33%. But it looked like the patients who did get oral azacitidine had a tendency to live longer, whereas patients who got investigator's choice had a response rate of 40%, but their overall survival was a little bit shorter. So we're not sure exactly why this might be, this phenomenon, but unfortunately, this did not lead to the approval of azacitidine. PI3 kinase inhibitors, we mentioned, duvelisib is the one we talked about initially, based on the PRIMO study, which showed an overall response rate of about 50%. This study is now completed, and we're hoping that this drug might be available for patients in the upcoming future. But there are other PI3 kinase inhibitors also in development. These include a drug called tenalisib and a drug called linperisib. And so I think we know that this class is important in T-cell lymphomas. It looks like consistently the response rate is near 50%, which surpasses the available drugs as well. So we think this is a super important group of agents in this disease. Additionally, there's been the advent of EZH2 inhibitors. EZH2 is another protein that helps to bind to histones in a complex, and that also regulates gene expression and the microenvironment. And so EZH2 inhibitors are approved for other lymphomas, including follicular lymphoma. Valemetostat is an oral EZH1/2 inhibitor that's been studied in adult T-cell lymphoma leukemia, where it's approved in Japan for that indication. It was recently studied in T-cell lymphoma in an international study as a single agent that's completed, with hopefully results being presented at ASH this upcoming year. And the exciting part about that, at least from the initial study, was that in the 44 patients who were on the very initial study of valemetostat, the response rate was 55%. And it seemed that the durability of these remissions was quite long, and the drug was quite well tolerated. So we're excited to hear about more about what this will bring at the upcoming ASH meeting. The other pathway that we think is important is JAK-STAT. JAK-STAT, just like it's important for many other forms of hematologic malignancies, is upregulated in various degrees in T-cell lymphoma. There have been multiple JAK inhibitors that have been studied, including a drug called sertolatinib, a drug called ruxolitinib, which is available for other hematologic malignancies. And then more recently, golidocitinib is an oral JAK1 inhibitor that was studied in a study of 112 patients. And it looks like it works also in about 44% of patients. And for the patients who responded, the median duration of response has not yet been reached. So there's updates to this study that was recently presented at ASCO at the upcoming ASH meeting as well. And it seems, again, that the patients who had angioimmunoblastic T-cell lymphoma, of which there were only like 16, seem to have an increased propensity to this drug also. No talk nowadays is complete without talking about checkpoint inhibition in cancer care. So checkpoint and PD-1 and PD-L1 are overexpressed in many forms of T-cell lymphoma. Unfortunately, we found that in certain types of T-cell lymphoma, they really help a lot. So in NK T-cell lymphoma, a disease that is more common in Asia and South America, this class of agents have been very effective. The initial series showed there were 5 of 5 responses. Subsequent studies have shown the response rate's about 60% with most of these agents. So very, very exciting for this rare and disease of unmet need. But in other diseases, it looks like it can cause hyperprogression, like giving the checkpoint inhibitor can actually make the lymphoma work faster. And so we have to proceed with a lot of caution. That's been seen now twice with these checkpoint inhibitors in T-cell lymphoma. And it's we're learning about when to use them and how to use them wisely. And there's some studies studying this in combination with other agents like PI3 kinase inhibitors. One of those we're leading here at WashU in skin lymphomas. That was conducted by Lauren Shea when she was here. Additionally, there are use of CAR T cells, right? So CAR T cells are genetically modified immune cells that are taught how to kill the cancer, have revolutionized the treatment of patients with diffuse large B-cell lymphoma. They're made from T cells, so it's been very challenging to figure out how to build a CAR T cell against T-cell lymphoma that doesn't kill the other CAR T cells, and finding the right antigen. So in CAR T cells, there's been the development of CARs against a protein called CD5, a protein called CD30, protein called CD7, a protein called CD70. And those studies are ongoing across the United States and across the globe to try to use this class of therapies in T-cell lymphomas. And here at WashU, we recently opened a study using an allogeneic CAR, so a CAR that you don't have to manufacture from the patient cells, but can be available to patients through donor cells, making it more accessible for patients and decreasing manufacturing costs. And so more to come on that. And that study is being led by Michael Kramer, who's a fellow here as well. So I think in the end, I see a lot of patients with T-cell lymphoma who unfortunately don't have the best outcomes, and that invigorates me to say, well, we got to do better than we're doing now. And whether that means making better treatments for patients with relapse disease, bridging them to allotransplant, or making more tolerable treatments for patients who can't get an allotransplant, that can hopefully lead to improving strategies in the frontline setting, and then hopefully predicting from the beginning who's more likely to respond and who's less likely to respond using imaging techniques or minimal residual disease techniques or gene expression profiling techniques that hopefully will ultimately gear and personalize treatment for patients based on their histology and based on their biology. And ultimately, we need to translate this to the community and improve access to care, because not everybody is fortunate to live near a large academic medical center and have access to all of this information. So for rare diseases, the dissemination of this information is critical. And we hope that one day, we're not going to treat all these diseases as one lump sum, but we'll really treat them based on the category and the biology of these diseases, which can lead to better treatments for them in the frontline setting and the relapse setting, and ultimately result in better survival curves and better outcomes for our patients. And with that, I'd like to thank all the people that I get to work with every day, including all my fellow lymphoma doctors at WashU, my mentors, prior and former, my collaborators, as well as a number of our trainees who are instrumental in the work on these projects, and my funding sources. And most importantly, the patients who are willing to try something new in order to try to move the needle forward for patients in the future. With that, I'd be happy to answer some questions.
Thank you so much for honestly that wonderful presentation. And I learned so much honestly about not just T-cell lymphomas, but the different types, the treatment options, as well as the management therapy. So thank you so much for that.
You're welcome.
So I'll be passing our mic to our moderator, Gabrielle, to continue with the discussion session today.
Thank you very much. It was a pleasure to have you here at MedNews Week, and we are learning a lot from your work. Thank you all for coming, and welcome to Discussions with Global Leaders. I am Gabrielle, and we are excited to be speaking with Dr. Mehta-Shah. He is Associated Program Director of Hematology-Oncology Fellowship and Associated Professor of Medicine at Cancer Center, Washington University in St. Louis. She's discussing the latest about T-cell lymphomas. We have received a lot of questions, and we'll do the best to get through all of them, and with the time we'll have with you. So for the first question, I'd like to pass the mic for Dr. Lymphman.
Thank you so much. And thank you so much, Dr. Shah, for taking time to speak on our platform. We all know that you have a lot of clinical responsibilities, and even now you stayed way past your normal office hours just for this. So we just want to thank you from the bottom of our hearts.
That's my pleasure.
Thank you for that wonderful presentation. You spoke about the advent of CAR T-cell therapy. In non-T-cell lymphomas, CAR T-cells have had profound efficacy. A question that I have for you is, what is, and has it been determined, the limiting factor for the limited efficacy in T-cell lymphomas? Is it perhaps we don't have the correct target or set of targets, or the most ideal target as a whole? And a second question is, given the large advent of CAR T-cell therapies and cousins of CAR T-cell therapies like NK cells and macrophage CARs, do you foresee one of them having a long-term greater efficacy in the long term? Thank you.
Yeah, I think that's an excellent question. So I think, there's many different probably components to why T cell lymphomas are later in the game to CAR T cells or cellular therapies. One is that, CAR T cells, as I mentioned, come from T cells. So you're programming your own T cells to kill, the bad cancer cells or the bad lymphoma cells. But when you have a T cell lymphoma, the antigens that are expressed on the CAR T cell are often the same as the antigens that are expressed on the cancer cell. So then you can be in a position of something we call fratricide, where the CAR T cells kill each other before they even get to the cancer cell. So the first challenge was trying to figure out how to pivot the cells to not kill each other. And so then there were methods of kind of developing CAR T cells that not only gained an antigen to fight, but then also lost specific antigen so that they didn't kill each other. And so that took a while to develop those sorts of strategies. And then there have been multiple targets that have been studied. The first that was studied was CD30 in T cell lymphomas. CD30 is also expressed in Hodgkin lymphomas, where there's also not CAR cellular therapy options for patients. So a lot of those studies included Hodgkin lymphoma patients and T cell lymphoma patients. And the strategy wasn't like a slam dunk there in T cell lymphomas that I think led to some pause in the development. The other issue is that to collect the T cells, you have to have a normal reservoir of T cells. Well, when patients have had relapsed and refractory T cell lymphomas, the therapies that we use kill the normal T cells and the bad T cells. So it's sometimes harder to collect those cells from the patient. The third part has to do with studying rare diseases, and I'll touch on that a bit, from here, because I think that's more applicable to, honestly, to all of you. Most of you will not spend a lot of time seeing T cell lymphoma patients, but you may try to do work in rare diseases. And doing work in rare diseases requires a lot of advocacy. Doing those studies often have to be done at more centers because every center only sees a couple of patients or a handful of patients. So to accomplish doing those studies is harder. And as a result of that, they're more costly because they have to be done often on a larger scale in terms of how many sites. But then on top of that, they cost a lot of money. And so for companies, they're often less interested in studying rare diseases because ultimately the rare diseases are not going to make up a big share of their market share. And so there's a lot of, while there's many of us who are very passionate about treating patients with rare diseases, it does require a lot of advocacy to try to push companies and laboratories to study rare diseases. And that's also been a major issue. So I think now that there's been some of the early CAR T cell studies have clearly shown that there are patients who have had very impressive outcomes. The largest one of these, or the biggest example of these, is the CD70 CAR, which has been presented internationally. That's leading hopefully to a larger study in the future. Hopefully that will help. I think the other big thing that will help is the advent of allogeneic CARs. So CAR T cells. Right now, when you get a CAR T cell, you have to, if you were the patient, you get your blood drawn, collected, siphoned for the CAR T cells, you get the rest of the blood back to you. And then a number of weeks later, 3, 4, 5, sometimes, weeks later, you get your manufactured cells brought back to you in frozen for administration. And that takes a lot of time. And some of these patients are really sick, they can't wait that long to get treatment and to move forward. And so allogeneic CARs, which are derived from a donor, so they can be available just like you get, antibiotics or bispecific antibodies, they can be gotten off the shelf. They don't require manufacturing from the patient themselves. Those, I think, will improve their production and the feasibility of giving CAR T cells in this difficult, sick patient population. And your other question was about NK cells and macrophage activating cells. I think a little bit more to come. Most of the NK literature is suggestive that these forms of cellular therapy may be less toxic. And the question is, are they less toxic and just as efficacious? And I think we'll have to find out over time. Certainly in T cell lymphomas, using a different cellular cell to target the lymphoma is very attractive. But again, the NK studies are just now being done in leukemia and diffuse large B-cell lymphoma.
Thank you so much.
Thank you very much, Dr. Shah. Now I'm going to pass the mic for Madhuri. It's over to you, Madhuri.
Yeah. First of all, thank you so much for this presentation. Honestly, it was so interesting to me. And something that I'm very curious about that I feel we would like to know is more on the microenvironment of the tumor itself and different molecular targets. And something that I had read about was maybe certain therapies designed to target hypoxic regions in T cell lymphoma tumors. And this can apparently improve treatment responses and overcome resistance. So what do you think about that and what is about it
I
actually?
think there's a huge portion of the microenvironment. I think as we've learned more, some of these drugs that I even talked about today that have shown pretty promising response rates compared to what's historically available, we think a lot of them work based on the microenvironment. Like they're not really necessarily even targeting the cancer cell as directly as they probably are also disrupting the home for the cell and not allowing the cell to grow. There's not been as much about metabolomics in T cell lymphomas as there has been in other diseases. I think in general in lymphomas, we're a little farther behind than in solid tumors in that world. Certainly important work is being done. But I think there's a huge role of the microenvironment. When you look at the biopsies of patients with T cell lymphoma, they're not all flooded with just the abnormal cancer cells. They're often infiltrated very heavily by cells of the microenvironment, which is part of the reason why they're hard to diagnose for pathologists. But also speaks to probably the importance of the microenvironment. And so I think the field is kind of heading in that direction. Unfortunately, the original studies that were done in T cell lymphoma weren't done with all this like very close correlatives and biomarker analysis. They were just like looking for a drug to work and then like showing that it works. And then the why came after. And I think now we're kind of doing those simultaneously or one after the other.
Thank you so much.
Thank you again, Dr. Shah, for your enlightening discussion. Now I'm going to pass the mic for Billy.
Hi, Doctor. You discussed a lot of very interesting and exciting research that's being done to develop and evaluate some new treatment methods. But what are some other domains of hematologic cancers research that could soon help patients or that you're particularly excited about?
Yeah, so I think like in general across heme malignancies, the advent of bispecific antibodies, I think are going to be transformational as well. Similar to kind of the revolution we had seen with CAR T cells, I think bispecific antibodies, which are now, 3 of which are now approved, at least in the United States, for follicular lymphoma or diffuse large B-cell lymphoma, are going to be able to deliver immune-based therapies in a way that patients don't have to be attached to an academic medical center. They'll be available in the community. They'll be available to be given in infusion suites and in the future, maybe even just subcutaneously. So I think that will be a major revolution in the care of patients who have B-cell lymphomas first, where these drugs are already available for patients. So I think that world is very, very exciting. I think in the world of Hodgkin lymphomas, the use of immunotherapy and frontline therapy is extremely exciting as well. And how to combine that with chemotherapy has already shown in the relapse setting to dramatically improve outcomes now repeatedly. And we think that is true in the frontline setting as well, in a study that was done through the SWOG intergroup, through the US intergroup, using SWOG as the main site and in conjunction with the Children's Oncology group. At ASCO this past year showed that at 1 year, the patients who got immunotherapy-based chemotherapy regimens did better. And so I think that world is also very, very exciting. I think in the leukemia world and the myeloma world, there's tons of research being done. I will admit I'm not an expert in those arenas, but the use of bispecific antibodies and CAR T cells in myeloma, I think, will be a major paradigm shift, as well as improving minimal residual disease techniques in AML to select patients for personalized therapy is also going to be a big deal. So.
Thank you for that, Doctor.
Thank you very much. Now I'm going to pass the mic to Harshal.
Yes. Thank you so much, Doctor, for a very insightful presentation. So my question is, looking ahead, how do you envision the integration of emerging technologies such as AI and precision medicine influencing the diagnosis and treatment of T-cell lymphoma?
Yeah, I don't think that's a great question. I don't think we're there quite yet, but I think like that work is currently being done. You know, in T-cell lymphomas, when pathology is reviewed in a community setting versus at an academic medical center, the subtype differs in up to 25% of cases. That's been studied in a large retrospective series. And so we know that people who see this more are usually better at diagnosing these, but like not most people aren't, you know, seeing these diseases a lot more. Most community oncologists only see these diseases once or twice a year, if that. And so the community pathologists also have the same experience. So I think the development of AI-based platforms for diagnosis is going to be very, very helpful in these types of rare diseases that are often hard to diagnose, especially if these platforms combine not only immunohistochemistry but also gene expression profiling and integrate that data. And those data, once made available, those programs, I would imagine that they will become cost effective to be able to then disseminate such technologies to areas that are under-resourced as well, especially in areas where there's not a large body of pathologists able to execute, you know, path rating. And so I think it will become very, very helpful. But again, we're not quite there yet.
Yeah, sir.
So I will be doing the last question for today. Actually, it's more than one question. For our more junior attendees just getting into research and medicine, we would like to know what inspired you to pursue the field of oncology. How has this choice impacted your life? And if has it been everything that you had initially anticipated, what you were thinking about before?
Yeah, that's like, I could spend a whole hour talking about that. So you ended with a big question. So for me, I'll give you the very brief summary. My mom is a pediatrician. And so I had grown up kind of in an era where, you know, you took your kids to work with you when you had to work. And so I spent a lot of time in inner city hospitals in New York, where there's a high sickle cell population. Became very intrigued by genomics and the bloodstream, and how that one mutational change changes a person's whole life. And so when I was in high school, started to shadow in hematology-oncology, and then saw like the relationships that doctors had with patients in the oncology sphere. And, you know, took that piece of like that pearl about what I enjoyed, and then took it with me to medical school. And in medical school, thought I was going to pursue cancer care. I thought actually I was going to do pediatric cancer. That turned out not for me. And at the end of a general lecture on pharmacology, the head of the cancer center, his name is Steve Rosen, was super kind and was like, you know, if you want to interested in cancer research, just reach out and I'll put you in touch with people. And I was very naive, and I wrote a nice email, and he luckily wrote back and said, well, why didn't you meet with me? I was like, oh, I didn't know that was an option. And so I got to meet with him, and he introduced me to, he said, well, if you want to do clinical research, which is what I wanted to do, why don't you come with me to my skin lymphoma clinic, which is cutaneous T-cell lymphoma clinic, essentially. And I fell in love with the disease and the biology, and saw it was very clear in one day to realize there's a huge need for better treatments for patients and treatments that improve quality of life. So I continued to work under his mentorship all through medical school. And then when I moved to New York for residency and then later fellowship, he had suggested meeting with Steve Horowitz, who became my forever mentor. And so I would say, you know, to people who are in like an earlier phase in their career, you know, just know yourself really well. Like the things that you realize you like repeatedly are probably things you really do like. And then the things that you realize you don't like, which for me was surgery, and I realized I also really like talking to patients and not their parents as much. And so for me, like learning those things about myself over time and making those observations was critical. And then the things you love to do, you're going to want to do all the time. And so it doesn't feel like work when you do it. And so you do the things that you really like, and that's what will drive you, and ask the questions that you're really interested in, because that's what you're going to work on nights and weekends. Not the boring stuff. So was oncology everything I thought it was going to be? That's a super hard question. I think, when you go in one phase of your career, you have this idyllic view of the people that you work with, and and then you realize that they're also just people and not superheroes like you thought they were. And so then you realize that you're just a person too. So I have 2 kids. My husband's also in medicine. He's in academics. We have to balance our lives with our family time and with each other, and understanding what's important to each other is very important. So that partnership for me has been critical. And also being in a place where you have strong mentorship and people that you can really go to for advice, whether that's about work or science or patients or life, is also developing your work family is also really important. I would say it's probably even more fulfilling than I had initially imagined it to be. So.
Yeah, thank you. It's very interesting and inspiring to know more about you and your background. And I'm sure that you have answered the questions that many listeners may have as well. And mainly those who have interest for oncology or internal medicine in general. And we really appreciate your participation on this keynote. It was very interesting, really. And a huge thank to our speaker. It was an amazing session. Thank you all of the great questions, and to all of your attendees. And please continue to